Oh, I do for the recording. Hi. My name is Scott Arthur. I'm the Vice Chancellor for Advancement at the CU Anschutz Medical Campus. This is our second year of doing this. And, oh, hi, Amanda. Good to see you. It's been, I think this is our 8th or 9th time doing this. And it's just really been a neat experience for us. It's a priority of the Chancellor to really showcase some key areas of the campus to the community. And when we started this program, we had 10 people show up. And now it's grown hundreds to about 40 or 50 here today, so we're pretty excited about it. I think everyone realizes that addiction and opioid, that's very relevant right now and everything that we are experiencing as a country. And so I think you're really going to be excited about this program. How this is going to work is we have two speakers that are going to give a 20-minute presentation around that, and then Lee Newman here from our School of Public Health, he'll kind of just give you a quick overview from his perspective of the issue. After the two presentations, there'll be a panel discussion, and then the best part of it is Q&A. And so we really want this to be more of a dialogue than just being talked at to, although we're really good at talking about the work that we do. We're really good at that. We enjoy it. We get passionate. So with that, I'd like to introduce Lee Newman. He is one of our executives in the School of Public Health, and is doing some amazing work in terms of workforce and healthy living. Lee.
Great. I've got a mic. Thanks. Nice to see you all here today. The topic that we're here to discuss is something which, as you know, is above the fold almost every day and front of mind for many of us. I just got back from North Carolina, where I was visiting a couple of cousins who, one of whom suffers from opioid addiction. And the consequence for her and her family is that she gets to see her kids once a year because her husband has the kids and she gets visitation rights. She lives in a house right next door to her sister, who basically is her caretaker and sometimes warden and friend. This was a brilliant woman whose life was really, fairly much destroyed by opioids. And many of us in the room have stories to tell like that. I'm in the Colorado School of Public Health. I had started out in medicine and practiced medicine for over 20 years, and then about 12 years ago, came over here to this campus to be one of the people to help get the School of Public Health off the ground. And it wasn't until I had been here, I don't even know how many years in, but quite a few years, until it was probably about 4 years in, before I even became aware, except on that individual cousin level, of the scope of this problem. And I think many of us have been late to recognize just how severe this epidemic is. And we have challenges both on the prevention side as well as on the treatment side. We now have the burden of large numbers of people who are suffering from addiction, and with great gaps in terms of even knowing what the best approaches are for addressing chronic pain and how to best treat our patients once they're addicted to opioids, how to best help them manage with that. The prevention question, how do we stop our society from being hooked on these kinds of medications, is frankly an area where we're all in very much catch-up mode in terms of coming up with better solutions. So one of the things that I think has been, for me, a very exciting part, and it's part of my introduction to the speakers today, the exciting part has been that as desperate as this epidemic is for us right now, there are people on this campus and around this state who have decided to really take this on as their research focus, as well as their practice, getting out there into the community and addressing this issue. And I know we'll hear from Rob here in a little bit, and we're going to hear first about some of the addiction issues, but then we're going to hear more about what's going on this campus and around the state. We have a consortium with, what is it, Rob, now over 400 members of the statewide consortium with support from the governor's office, from the state legislature, and this it's a remarkable thing because most of these are people who are not paid to do it. They're doing it because they're passionate about it, because they care about it, because they recognize what a huge issue this is for them personally as well as for our society. And so I've been really privileged to be able to be part of the development of that effort. And so huge credit to the people on this campus and at various groups around the state who've been contributing to addressing this issue, and also to the high caliber researchers who are addressing these issues so that we come up with better solutions. What I'd like to do is introduce our first speaker, Joe Sakai, who's an associate professor in the Department of Psychiatry. And Joe and I actually don't know each other all that well, but I've known of his work for some time, and he's really a thought leader and researcher around the whole area of addiction. He's a graduate of Pomona College in California, graduated from Tulane School of Medicine, finished his residency and fellowship in addiction psychiatry, and did his postdoctoral training here at CU in the School of Medicine. His laboratory here on this campus is improving neuroscientific understanding of addiction, which he will decode that for us here in a few minutes. And really with the idea that with a better understanding of the neuroscience of addiction, he and his lab are coming up with better ways of having effective treatments for people with addiction. So with that, help me welcome Dr. Sakai.
So thank you so much first for inviting me here today to speak. It's a great pleasure. I'm so excited that there's a focus on addiction at this point in time. I think maybe that's one of the silver linings of all of these horrible things that have been happening. I just want to start by saying that my talk is going to be a bit more general. I think many folks who've come today were particularly interested in hearing about the opioid epidemic and strategies to really tackle that. Dr. Valak will address that in the second talk today. My talk is a little bit more generally focused on addiction around various substance use disorders. And it's also a bit more specific because I'm going to focus on the neuroscience of addiction. And in the last couple slides, just talk about some of the ways in which that neuroscientific information may be informing us about ways that we might better intervene in the future. So I have a couple of conflicts of interest that are important to tell folks to start with. Back in 2012, somebody from University Hospital asked me to review a policy statement on Vivitrol, which is a medication used for alcoholism and opioid use disorder. It's something that needs to be prescribed more frequently, and I was very happy to do that policy review. But I should have read the email more carefully because I received a check for about $150 after that, and now every time I give a talk, I have to say, I received money for WellPoint. So I also was a board member for a foundation until 2015. That was the Arts Foundation, and despite its name, it's not about the arts. It's about helping people with addiction. My lab has had support from the National Institute on Drug Abuse for many years, and some of the work that I will present today relates to that funding. And I also want to say a very big thank you to these two foundations, the King Family Foundation and the Hewitt Family Foundation. They have supported our lab over a number of years, and they really have allowed us to do phenomenal things. I think NIDA is wonderful, but they often like to do things that are tried and true. Those things that are truly innovative, they're a little bit worried about and not as supportive of. And these foundations have really given us rocket fuel in terms of what we can do in our lab. So very much like Dr. Newman, I want to start with a personal story about my grandfather, who was this wonderful man, loving Southern gentleman, an attorney, but who descended very deeply into alcoholism. My mother was very connected to him. He was the most important person in her life. But alcoholism began to come first. There were moments where she would be at school, 9 years old, waiting to get picked up, and everybody else got picked up and nobody came. And she'd go home, and there would be her dad passed out in the chair. He was never violent. He mainly just disappeared. He couldn't function at work, couldn't function in his life. He couldn't function as a father. And he eventually died from his alcoholism. Now, it turns out that I actually look a lot like my grandfather. And I have certain mannerisms like him too, which was incredibly anxiety-provoking for my mother as I moved toward adolescence. And I can remember having conversation after conversation with her about her saying, please, please don't go down that road. Please. And I think in part because of that, I made it through high school and college without ending up in those situations. And I arrived at medical school really excited about caring for patients. And one of the things that I saw over and over again was just how much substance use disorders were prevalent in the emergency room, in the clinics, on the wards. We saw so many patients with substance use disorders. And we often were really great at treating the injury that they had related to their fall. We were great at treating the pancreatitis. We were great at draining their belly from the ascites that they had. We were good at treating the cardiac condition, the lung condition, but we almost never did anything about the addiction. And then we would send them out, and when they relapsed and came back with an exacerbation of their pancreatitis, the physicians and the nurses were all often very angry and upset. And to me, it just didn't make sense. And so from this came a career focus and a passion, an area that I wanted to work on and dedicate my career to. And it also was a road to Colorado, because I searched for a physician who was interested in addictions, who was an expert clinically, but who also did research. And there weren't that many of them around the country at that time. But there was one here, and his name is Tom Crowley. He's retired several years ago now, but he had created these large treatment programs with many colleagues here that still run the ARTS programs. On any given day, they have about 1,500 patients enrolled in them. And they're a very robust and important part of the Department of Psychiatry's Division of Substance Dependence. They do methadone maintenance and Vivitrol and Suboxone and treatment for pregnant women and treatment for women and their young children. And he also had a very robust research program. And so I would say to Tom, I want to do research. That's where I want to focus. And he would say to me, become a great clinician. Your focus should be become a great clinician. And so I focused on training in addictions work, subspecializing in that area, doing postdoctoral work in that area, and really focused on becoming an excellent clinician. And from that then, though, I began to expand in education. And so I'm the director of medical student education for my department. I'm the associate training director for the addiction psychiatry program and fellowship in our department as well. And those are areas that are very important to me in terms of developing the workforce in the future to treat individuals with addictions. But it strikes me, and it struck me over the years, that patients use so many substances. It's not just alcohol and tobacco and cannabis and cocaine. And these days, heroin and opioids really on the rise and killing way too many people. But crystal meth and LSD and ecstasy, barbiturates and sedatives and inhalants and PCP. But the list gets longer every year. So a few years ago, we began to have problems with spice. By a show of hands, how many people have heard of spice before? Yeah, so a lot of people. These synthetic cannabinoids that are created in the laboratory. We see folks using salvia divinorum to hallucinate, or using bath salts, which, by the way, don't put them in your bath. They are not food acids. They are stimulants, and they use the name bath salts to evade legal sanctions, right? I've had a youth who would take morning glory seeds and create a tea to create a delirium. We have many youth who shoplift Coricidin and cold and cough for the dextromethorphan that's in it to hallucinate. And I even had a youth who would use high doses of nutmeg to try to get intoxication as well. The list gets longer and longer and longer each year, but the substances that we actually have medications to treat are few and far between. We have medications for alcohol use disorder, opioid use disorder, and nicotine use disorder. But despite years of work We have no medications to treat cocaine use disorder, methamphetamine use disorder, and so on. We have a number of psychosocial treatments, and we use those in our treatment programs, and they are effective. But they generally have a moderate effect size. We don't have really high effect size treatments, and we have a number of patients who, despite our treatments, relapse, and some of whom suffer great morbidity and even mortality. So that's brought me to really focus over the last 20 years on research as well. And our laboratory has been focused on better understanding the neurobiology of addiction and really focusing on the underpinnings of early onset substance use disorders with the hope that we can one day have more powerful treatments at the bedside. So there is a lot of work, and there was when I started out, on adults with addiction compared to controls, looking at the neuroscience and demonstrating that there are differences. And this is one example. This is work from Nora Volkov, who's the director of NIDA, showing that there are differences in terms of receptor availability within the reward circuitry. And there are two circuits that from that adult literature really jump out as being important. The first is a reward circuit, which starts in the midbrain of the brainstem and extends up to an area called the nucleus accumbens. When you stimulate this, it feels good. It's rewarding. It drives you back to do that behavior again. It's involved in learning, but it's also involved in mood as well. The second circuit is a frontal control circuit. The frontal lobes, the front part of the brain, are involved in things like inhibition, planning for the future, evaluation. And so these two circuits, again and again, in adult literature, come up. But one question is, if you take a patient with 30 years of alcoholism and you show that their brain is different, is it because of the toxic effects of drugs that have been exposed to over a 30-year period? We know from the animal literature that if you expose an animal's brain repeatedly to substances of abuse, there are changes that occur in the brain. So as an example, this is just a representation of some data from George Koob's lab, who is the director of NIAAA, and essentially showing that in the nucleus accumbens, that reward circuit, that if you administer a drug of abuse, you get a big surge in terms of the release of dopamine. It is very rewarding. All substances of abuse work in that circuit. All substances of abuse cause a very big surge in terms of release of dopamine in that circuit. Okay? But if you expose a rat to a drug of abuse over time, what happens is eventually the basal levels of dopamine in that circuit decrease. So eventually, the rat is just trying to get back to what was a normal mood state. And there is this sort of dysphoria or anhedonia that occurs as a result. So if we have an adult with 30 years of exposure to substances and we compare it to a control population, it could be the toxic effects of drugs, but we want to really know what mediates the drive toward addiction. And so we have really focused on adolescent populations, those with an early onset, just a few years of a substance use disorder. And so you can see from this graph, these are alcohol dependence, cannabis dependence, and cocaine. And essentially, this is age in years, and this is the risk of developing a new onset alcohol dependence. There is, in the adolescent years, this very steep ascending curve, and it peaks at about age 18. That is your age at which you are most likely to develop a new onset alcohol dependence diagnosis. And so we look here at adolescents with just a few years of substance exposure and try to find differences that may be related to the process of addiction. So the second question that we wanted to really look at is, lots of youth try substances. About half of high school seniors have used an illicit drug. The majority have used alcohol. About 1 in 6 report that they binge drank in the last 2 weeks. Yet not all of those youth go on to develop a substance use disorder. Why do some people go on and progress and others don't? Is it predictable or is it random? And there is a good deal of data now to show that it is predictable on average. Okay? So this is one of these studies. This is 1,000 youth enrolled in the study at birth and followed until they were 32 years in the study, 32 years old. And in childhood, they measured something that they called self-control, inhibition, aggression, being able to delay rewards, things of this nature. And what they did was they took this child level of self-control, measured at about age 7, and then they saw if there was a relationship in adulthood with substance dependence. And what they showed was those with low childhood self-control were much more likely to in adulthood have substance dependence. It's not random that there are certain things, even in early childhood, that predict, on average, a risk for later developing substance dependence. So we've taken those kinds of measures. It's called different things in different studies, and this is a colleague of ours, Susan Young, who was up in Boulder and now is over at Children's Hospital. And this study is several years old now, but essentially she took something very similar to that idea of self-control. And she said, is it mostly environment that causes that, or is there a big genetic component? And she used a twin sample to look at this. And she found in her study that 84% of the variance was related to genetic differences, that there was a very strong genetic load on this risk for later developing substance use disorders. So we have really focused on trying to get at, within the MRI, a machine where we can look at blood flow in the brain pretty much in real time, not perfectly, to look at what happens in the brain as people make decisions. And we've looked at a lot of different factors, a lot of different paradigms, but two that have been really important areas are really looking at impulsivity and inhibition and this idea of sensation seeking and anhedonia. And if you think back to that frontal control circuit, the front part of the brain, that's involved in inhibiting behaviors and planning for the future. And that really maps onto these kinds of behaviors. And sensation seeking and boredom and wanting to seek out something that's more exciting, that's really mapped onto the reward circuit, okay? And so we've done a lot of papers, too many to review in detail in 20 minutes, but I'm going to take you through a couple of really key ideas here. We take simple games, but from those simple games, we can learn quite profound things. And so this is a simple game created by a guy named Carl Lejway, where this is a balloon, not great animation, right? But you can press and puff up the balloon, and every time you press, a little bit of money goes into a bucket. And if you press it, you get more money, more money, more money, but eventually the balloon will pop. And if it pops, you lose all the money you collected. So you have to decide, should I take a risk or should I be cautious? Should I take a risk or be cautious, right? And so how many times people press is a measure of risk-taking. So what you'll see over here is the number of presses for each of 22 balloons. These are adolescent controls, and then these are adolescent patients. And you can see from the very first balloon that our patients take a lot more risks. They tend to pursue a lot more risks. So we've done a modification of this paradigm in the MRI machine, and we've had patients early on with a substance use disorder and controls without a substance use disorder play this game in the MRI machine. And what we can show is that the controls have lots more brain activation as they decide about whether to take a risk in areas of the frontal control circuit and in areas related to reward. The patients have a lot less activation as they make those decisions. So it's not just 30 years of alcohol exposure, 30 years of cocaine exposure. We can see it very early on. But the next question is it just a year of substance exposure that causes this? And so we've actually recruited 9 to 11-year-olds, those who have no exposure to substances yet, or very little. And we've done the same thing for them. And we've used a measure that we know predicts later substance use disorder risk to look at what happens in the brain as these children make decisions about whether to take risks or not. And we show the same thing, that higher levels of this risk factor for developing a substance use disorder are related to lower levels of activation in the reward circuitry. So if you think about the accumbens right here, and also the midbrain, and then also in these frontal medial regions involved in planning and control, inhibition. So where does that leave us? We know that some youth are at risk for developing substance dependence. And they have differences. Their brains function a bit differently around deciding about choices whether to pursue a risk or to behave cautiously. As those youth then are at greater risk for using substances, those substances then further reinforce those problems in those brain circuits. We've seen it in animal literature, we've seen it in the adult literature. So it's sort of a double whammy, that they are predisposed towards substances, and then the substances further damage those circuits and the functioning. We are at a point now where the circuits involved in addiction are pretty well specified. They're not perfect, but we know a lot. And it's amazing what's happened over the last 20 years. So this is a model that Koob and Volkov have put out, but essentially contains much of the same material. This idea that the reward circuit is deeply involved, that frontal control circuits are deeply involved. The question is, what do we do next? What comes from this? Is it just a scientific experiment to try and figure out what's different? Or do we really want to try to intervene? And so people have begun to do studies in animals where they actually alter these circuits. And there are procedures to be able to do this. And showing that they can reduce drug self-administration by altering these circuits. And now people have begun to call for doing these kinds of studies in humans. And in fact, these kinds of studies are starting to be done. So for example, this is a study, I don't know if folks saw this National Geographic issue 2 months ago, but it reviewed this small study, this is the front page of that study, by an Italian psychiatrist who said, I've tried to treat cocaine dependence for years, it hasn't worked very well, and I'm going to start using this procedure called TMS, which essentially places a coil near the scalp and alters the excitability of neurons at the cortex. And by repeatedly administering this, he was able to show reductions in cocaine use in people, right? So what was he doing? He was trying to bolster the frontal lobes to improve inhibition and planning. And so, quite interesting, an initial study. And this is a bit more out there, but there is these subcortical structures, which is the brain's reward circuitry, which drives that sensation-seeking and reward-seeking, is not accessible easily from these non-invasive procedures. But there is something called deep brain stimulation. It's done all the time for Parkinson's. It's done now for obsessive-compulsive disorder. And it involves placing a thin wire through a small hole in the skull down to a subcortical region and actually applying stimulation through a battery continuously. And interestingly enough, this reward circuit, placing these wires into the nucleus accumbens bilaterally. There's a study in Germany doing this for 5 patients, where essentially they showed all patients reported complete absence of craving for alcohol. 2 patients remained abstinent for many years. 3 showed marked reduction of alcohol consumption. So by altering these circuits, it may be an avenue to create more effective treatments for patients. Now, I will state that these studies only enroll patients who are adults, who've had really chronic and severe problems, and who have been refractory to the standard treatments that we have. Okay? But this is an area that our lab is intending to move towards. So in summary, just to say, substance use disorders are common and cause a substantial amount of morbidity and mortality. Not all individuals have similar risk for developing a substance use disorder. We know a great deal now about the neurocircuitry undergirding both the risk for and development of addiction, and recent small-scale work, often done outside the United States, has begun to explore whether modification of those circuits can impact the course of addiction and associated markers. So thank you for your time.
Thanks, Judge. Thank you, Dr. Sakai. So you have pads. We're not going to take questions for Dr. Sakai yet, but you're going to get a chance to. So you have pads, and please jot down your questions, your ideas, so you remember them. We're going to now hear from Dr. Rob Valak, who's a professor in the School of Pharmacy. So he's in pharmacology, in epidemiology, in family medicine. And I mentioned to you earlier the Colorado Consortium for Prescription Drug Abuse Prevention. He's the director of that, He's the founder of that. Governor Hickenlooper probably knows Rob on a first-name basis by now, as do most of the members of the legislature, because he is out there. And anytime you read in the paper about this issue, they're usually turning to Rob for a comment, a quote, because he has been one of we always say, oh, he's a leader. No, this guy's really the leader of a statewide movement to address the epidemic of opioid misuse and abuse. So with that, help me welcome Dr. Valek.
Thanks, Lee, and thanks everybody for coming out. It's a real little treat for me to be able to talk with this group and to follow Joe. I mean, I will give first the most important disclaimers. The work that I do is not important in the way that the work Joe does. The real advances in treatment and successes that we're going to have are going to come from science, and they're going to come from clinical medicine, and they're going to come from people like Joe. So it's a real pleasure to hear his talk, and it's like I listen to that, and that's the cool stuff, is what's going on, to figure out what's going on and how we address it and come up with better treatment. So it's love following you, but I also find it a challenge because I think that's where the real progress is going to be made. But I'm going to follow that and kind of go to the different level. It's an interesting complementarity of these talks, I think, that Joe's talking at very much the molecular and the biophysical level of what's going on with addictions and potential modalities for treatment. And I'm going to talk at the kind of 30,000-foot level about what's going on with, how big this epidemic is and what it looks like at the very tail end of what happens when the addictions go and become what they are now is at the societal level, and how we look at them and try to address them on a large scale. So I'm going to try to do 3 things in 20 minutes, which is impossible. Any of these, 2 of my slides could take 20 minutes. But I'll try to do a quick overview on the scope of how big this epidemic is, a little bit on how we got here, and then what's being done. So I'm going to try to cover each of those in 5 or 7 minutes each, roughly. So first, to talk about the most recent data on the scope of the opioid crisis. Because definitely, if you hear the words talked about, the opioid problem, the opioid epidemic, the opioid crisis, pick a descriptor, it's a big deal. And just how big is that? The first number people tend to look at and hear about is related to overdose mortality. How many people are dying from opioid overdoses every year? And the number is skyrocketing. Last year, over 63,000 people died in the United States from a drug overdose of some kind. And so this includes all drugs, though. Antidepressants, accidental overdoses from Tylenol. I mean, any drug overdose at all is counted in this drug overdose number. So you hear these, but I think it's important to lay out the ones that are commonly you'll see in the media. And this is one of them, the 63,000 number. And that's 1 every 10 minutes, or 12 more during this 2-hour session are going to die from drug overdoses. It's really a big deal. Nearly 2/3 of them are from prescription drugs. But again, 1/3 of them are not. They're from illicits or from over-the-counter medications even, like Tylenol. It does kill people. And you can overdose on it, and accidentally or intentionally. So that's a problem across the board for anything that you put, if I tell people, anything you put in your mouth, if not taken right, can do you in. Most of those, though, are prescription opioids that are driving this problem. 75% of these are related to that, of the drug ones. So it's a big deal. In Colorado, there were 912 drug overdose deaths last year. 504 are on the number that we track in the consortium, are the opioid overdose deaths. And this is the prescribed ones, like Vicodin or OxyContin or whatever, so a prescribed opioid, or an illicit one, like heroin or illicitly obtained fentanyl, the analogs like that, the synthetics. So either one, you put those together, and we track that number year over year to kind of try to get a sense of how bad is this and what progress might we be making. So if there's any good news, and that's what I say my talk is usually, I'm kind of like the little black rain cloud, is usually mine is, but I always have, there's one little tiny nugget of good news, this is it, focus on it, is that the number of prescription opioid overdose deaths alone, so if somebody is overdoses and dies and you do an autopsy and find out what's in their system, and it's only a prescribed opioid. So those deaths are actually starting to come back down. They've been going up for many years, for 25 years they've been climbing. And finally, for the first time in 2016 over 2015, that number's coming down. They were at 329 in Colorado, and that's down 10% to 300. Still an alarming number. But for the first time, we think we're starting to bend the curve on isolated, prescribed opioid overdose deaths. The bad news is just about everything else is going up. Heroin-related deaths are up from 162 years ago to 228. Fentanyl deaths from 41 up to 49. Methadone deaths from 34 to 56. All of those are up sharply. So the net gain, we went from 472 2 years ago to 504 in 2016. And it's gotten to the point where it used to be about 80-20 with prescription drugs and heroin and the synthetics. Now it's about 60-40. Heroin and synthetics are climbing, and we're, again, starting to bend the curve a little bit. So the current proportion is about 60-40. And we look at that as well to see what's going on in the marketplace from that. So that's kind of where we are, which is, again, very troubling. To the point where, we ask, we got to find out where is the problem? And people ask me that now. Where is it worst? And I just ask, well, where are you? That's where it's worst. It's gotten to the point where there is no isolation. This community doesn't have that problem, or this age group does not have this problem, or this gender. Not true. This knows no bounds, and that's why CDC does view it this way and calls this a top 4 epidemic. Cancer, heart disease, obesity, prescription opioid overdose death. And people know about the first 3 and would say, yes, I know cancer is a big deal and we have to be addressing that. But this is what we need to elevate the conversation about this topic into that level because of the numbers of people dying. And then I'll show you in a minute for the numbers that we're really worried about is who's sort of queued up and at potential very high risk. If you look at drug overdose mortality in Colorado, the point I was making a minute ago is that this started out, this is in 2002, and this map shows overdose deaths, but the rate of them per 100,000 populations. We tracked the number per 100,000 in 2002, and the darker counties are worse. So 0 to 2 per 100,000 is over here. If you're really dark red is more than 20 per 100,000, and at that time, the average was about 10. So the middle color in here, mid shade, is about average, national average. And if you look around the state already in 2002, city and county of Denver, and the San Luis Valley, and the upper part of the lower Arkansas Valley, but those areas were already above the national average and experiencing problems. And if you talk to people from the San Luis Valley, which we have for many years, this is not new. This is 25 years ago. They're saying we've got to start getting a handle on this. We're starting to see the early signs, and this is like 1990 when I was having those conversations with them. So this is not a new thing in the San Luis Valley by any means. But if you watch this over time, year over year for about a 12-year span, how the overdose death rates continue to climb. So that by 2014, and I don't have the data plugged into this graphic because I'm not smart enough to do it. I have to wait for the people who made the graphic to do it. It got worse. So again, you saw the numbers. That these are just getting darker. And people wonder if Mineral County is a drug-free zone. It's not true. There's just, if I know the 4 people that live in Mineral County, none of them have overdosed and died. And if one of them does, they're all of a sudden at 25%, and theirs is the darkest red square in the state. So it's really just a function of very small sample size in Mineral County. But otherwise, there's not much different about Mineral County than anywhere else in Colorado. So we have this huge problem that there's a 500% increase in a 12-year span in the rate of death due to a single cause. And epidemiologists think, that's where people like me with this training in pharmacy and epidemiology, this is when we freak out. We see cause of death accelerating at that rate. Something is very much a concern. So we've seen these trends over time. Back when I was in training, it's not important when this was, but it's somewhere in this area. It was about 4 per 100,000 per year. And then it doubles by the end of the 90s, triples by the end of 2005. And now this number here, this is an older graph, but this is now about 15 is the national average in overdose deaths per 100,000. And you compare this to other causes of death, like motor vehicle deaths, are more like 9.5 per 100,000. We've gotten to the point now where, as a cause of death, drug poisonings were very low and have now climbed steadily to the point now where we're almost to 15. Other causes of death, like motor vehicle traffic deaths, have steadily declined with advances in automobile safety, airbags, seatbelts, guardrails, all sorts of things. Cars are safer, so the rate of death is going down. Even firearms, recent events notwithstanding, firearm-related deaths are going down and have leveled off, but that it's now are exceeded by overdose deaths, drug overdose deaths. So it's again, a major concern. It's one of the reasons why, for the first time in history, lifespan for males over age 50 is going down, because enough males over age 50 are overdosing and dying after a long history of substance use, and it's a very high period from age 45 to 55 for overdose death. It's causing the lifespan to go down for the first time since we've tracked and calculated and tallied lifespan. So again, very big deal. And the big driver of this being the prescription opioids of these deaths. So yes, people do overdose and die from other things. They overdose and die from meth or from other things, but it's, again, much less frequent than prescribed opioids. But as I mentioned before, this is just the tip of the iceberg. These overdose deaths are extremely important, and obviously this is the final outcome. And if there's this many of them, 33,000 for the opioids. For every one of those 33,000 deaths, though, there are 10 people who would get treatment for a substance use disorder, 32 people that go to the emergency department for the substance use disorder for a reason related to it, 130 people who meet diagnostic criteria for a substance use disorder, and perhaps most troubling of all, and if you ask me, the one that scares me the most, is for every one of those 33,000 opioid overdose deaths, there are 825 people who admit and will self-report non-medical use of an opioid in the last year. And when we do these surveys, they're done every 2 years, the National Survey on Drug Use and Health, this is one of the questions, is asking about, have you used a prescription painkiller that was not for you, or was for you, but if you're using it for something else, like you got it for your wisdom tooth 4 years ago, and now you're using it for something else. And this is the rate of people that will admit that. And as you can imagine, it's probably somewhat higher. Not everybody will admit it on a survey. So the number is, that's what's scary to me. You take 33,000 and multiply it by 825. This is the at-risk pool for people who are non-medically using opioids now, and we're worried about progressing up this pyramid, because that's the people who are then most likely to become dependent and have tolerance, and then ultimately become addicted and have these consequences, and ultimately some fraction of them will die. So this is very scary. And so worried about not only the number now, but it's kind of the latency period. If we see this curve bending a little bit perhaps, but all the people who are still actually non-medically using opioids that we have not detected yet and have not come and tried to even seek out medical treatment. It's frightening. It really is a frightening number. The cost is very high. These numbers, I think, are woefully underestimated from the sources. I've looked at there's very few data on what's the total impact to society of this, but it's been estimated that as recently as 2013, this may have been an $80 billion a year problem. Medical complications are expensive and cost about $1 billion to the health system. That's a lot of money. Treatment, even more, $3 billion. Criminal justice involvement, 4 times that, $12 billion in criminal justice costs. It's really our de facto substance use disorder treatment system in the United States still is criminal justice over real, medical treatment. Is more in the criminal justice system, which is a serious problem. But really, the biggest impact to society, 79% of it is in lost productivity. People not able to work as well as they could, or missing work, or losing jobs, impacting families who then have to do caregiving, as has been mentioned. All of these impacts to society, the biggest cost of all is in the lost productivity. So it's something we all face, and it affects all of us all the time because of it. So it's something that no matter which angle you are motivated by any of these issues, it's one of these. I'm trying to present something for you, that there's something here that will hopefully grab each of you and say, geez, this is a big deal that we need to address. Obviously, we need treatment for folks that need to get it. Joe is trying to help develop ways for how do we find medications and other mechanisms to understand addiction so we can create better treatments. Right now, we simply don't have them. We don't have enough capacity either. For all those people that need treatment, we still have what's approaching a 90% treatment gap. We think, we need about, 21.6, and some, numbers I read now are between 28 and 30 million people needing treatment now, right now. People getting it, somewhere between 2.5 and 3 million. So these numbers are adjusted slightly. The ratio is not that much different. So we simply have this 90% treatment gap where it's not like if you have cancer and you walk over to the CU Cancer Center and you say, sorry, we only have enough, enough treatment for 1 out of 10. Sorry, you have to turn away 9 out of the 10. Or you can't find oncologists. 9 out of 10 can't find one. Or it doesn't have coverage for chemo. That's where we are with substance use disorders. Is that kind of a situation with treatment. We simply don't have it. Even with all the good treatment that goes on, we're woefully under minimal capacity to deal with all of the need that's out there. So it's a tremendous problem. We try to expand this with, buprenorphine outpatient treatment, buprenorphine prescribers. We have very few of those. We have in the couple hundred range of doctors in the state of Colorado that can and do prescribe buprenorphine, an outpatient-based form of treatment. With that, we have 5.5 million people in Colorado and 250 active prescribers. It's not enough. So we're working very hard to try to increase and train more. But boy, it's hard for Joe and his fellowship room to train enough people to meet that need. That could take a couple thousand years at the rate we're able to produce them. It's really a difficult, vexing problem. So how do we ramp up capacity in these excellent clinicians to do this work? So how did we get in this mess? It was a lot of things that contributed to it, but really I always just tell people, follow the opioids. Where the opioids go, the problems go with them. Over the last 20 years, we've had a 4-fold increase in the amount of opioid on a per capita adjusted basis that's gone into the population. So we've cranked up how many opioids we give out. We've done that over about a 25-year period. And as we've done that, we've gotten to the point where over a quarter billion, 250 million prescriptions go out a year at retail. That's how many opioids go out. And on average, 58 tablets. This becomes over 10.2 billion dosage units a year go out from pharmacies into medicine cabinets. The sheer volume of product that does that is a big deal. And with that goes all the problems. Overdose deaths and treatment admissions, all those things follow along. As you know, addiction is complicated, and Joe has done a much better job describing that than I could, so I will let him do that. But it's been a lot of, well-motivated, I think, originally in the 80s. We need to treat pain better. We need to try to address this. We need to elevate the conversation about pain so people's pain doesn't go untreated. But then we've had this pendulum swing the other way, to the point where basically we've gotten into a situation where, at least in the United States, pain equals opioid. You walk in, and if you don't get a prescription for Vicodin, people feel gypped. Doctors don't know what else to do. And they also know their patients are expecting it. And if it's the easiest way to be done with an interaction is write the Vicodin script and where everybody's happy. And it's a wonderfully terrible thing to do, is to give out opioids like that. It's just not a good idea. So where does it really start? We don't give out in Colorado. People say, we give out too many opioids, and we do. But Colorado's about 37th in the amount that we give out as far as per capita, the amount that we dispense. So we're not among the leading states that way. But we're number 2 in our willingness to try it non-medically. So whatever's left over in the medicine cabinet, people here are willing to try them non-medically. So our risk aversion is lower, our risk perceptions are lower, and our willingness to try things non-medically is higher in our state. And that's a deadly mixture of things that we're worried about. Where do people get them non-medically? Over 70% of people get these from the medicine cabinet. It's the 10.2 billion tablets that are sitting around in medicine cabinets that people have easy access to. And that's where most people start. 70% of people that end up with a bad consequence started there. Leftover stuff that wasn't theirs. So check your medicine cabinets when you get home and dispose of stuff. Other problems are, yes, if it was prescribed for you, people that admit, there's about 17% that admit, yeah, it was leftover. I had that from a wisdom tooth or my toe or whatever, and a year later I used that for my back pain or my headache. So that's also a problem. And the third problem is after surgery, people, well-motivated clinicians, surgeons will say, hey, after this, I just cut on a person. I may have replaced their hip, whatever. This is really violent stuff they're doing to someone's body, so I'm going to give them some opioids because I just did them harm. So I'm going to give them some opioids. But after a year, we see that no matter whether it's a minor surgical procedure or a major surgical procedure, almost doesn't matter. If you start somebody on an opioid, 6% of people are still going to be on it a year later. 6%. This is not rare. People say if it's 1 in 1,000, it's like, well, we got to. But 6 in 100 are still going to be on that opioid a year later. And this is post-surgical for opioid-naive patients. So this is what we call the fire-starting problem. It's starting fires that we don't realize are becoming wildfires later because they just provided care for a month and everything was fine after the surgery and didn't really realize what happened. And I think well-intentioned pain management. So, what are we trying to do about this? The good news is a lot is going on. From the top at the federal level, the President's Commission recommended a number of things, like declaring this a national public health emergency, which was done, which is fully appropriate. Probably should have done more, but it's fully appropriate. No one's denying that that's an okay idea to do that. Doing more with treatment expansion, continuing education, things like that that are recommended. We'll see what the commission ends up doing and what the president ends up doing in the agencies based on that. We don't know yet. We do know the declaration's been made, and we're waiting eagerly to hear what's that going to turn into. CDC, the Centers for Medicaid Medicare Services, the FDA, the DEA are all doing what they can within their scope to try to do things, make it more difficult to prescribe. We'd say, hey, docs, you can't write refills for Vicodin anymore. So it's little things like that that make a big difference. So things that the feds are doing. More funding coming from the feds to expand treatment. You heard about the 90% treatment cap. Feds have heard it too, and most of the money coming from the federal level, 80% of it is going straight into treatment expansion, as probably should be. And at the Colorado level, we have a strategic plan that we created several years ago that led to the creation of this statewide organization called the Colorado Consortium for Prescription Drug Abuse Prevention. And we have basically a multi-work group structure of almost 500 people now participating in this work with experts from state agencies, professional associations, universities, treatment community, all of that to try to do this work in a variety of ways. And we do that everywhere from raising public awareness to educating doctors, increasing safe disposal programs because of the medicine cabinet problem. Now we're trying to get disposal boxes in every community in Colorado so people can take back the meds when they're done with them and not have their neighbors, friends, children, whatever, getting into the medicine cabinet and becoming one of those people that non-medically uses what's left over. Single biggest piece of low-hanging fruit is that one. But we're also working on increasing access to the overdose reversal drug naloxone. Over 90% of those overdose deaths, the 33,000, are preventable if people have the antidote, but most people don't even know it exists. So we're trying to push that into the work group. And so we have a lot of other stuff going on, to expand access to treatment, focus on recovery support. Every aspect of this problem, we would welcome any of you. We would love it. It's like Lee said, it's a volunteer organization. We would love to take your time uncompensated and come and have you be part of this work. We've managed to keep this thing going for 5 years with people who are volunteering their time because I think of the importance of it. Nobody thought it would work, at least of all me. And last but not least, I'll mention that we do have our legislature in Colorado very engaged in this now. The Interim Study Committee, you probably saw this in the paper last Sunday in the Denver Post, talking about 6 interim bills that they spent 3 months listening to the consortium, task forces, all of the stakeholders getting together to tell them where are the problems and what should we do to fill in where there are gaps that the legislature could address. And that committee was terrific, and it focused on 6 different areas. Those bills are summarized. You can look those up in the Denver Post or on the web. But they're trying to say, hey, how do we view this comprehensively and do everything from prevention to better clinical practice to harm reduction to treatment to recovery? And how do we try to manage that and find where those gaps are? And these bills are a very comprehensive package, so you may hear more about them if you haven't already. That's a very high-level overview. I know I went over my time. I'm notorious for that. Thank you.
So if you come up. Thanks, Rob. So what we're going to do now is we're going to have a little panel discussion. I've got a few prompt questions just to kind of get the ball rolling, but we really want the rest of our time together to be a conversation, which means that we want questions, and if you have answers, we want answers. So we're going to have all 3 of us up here, and we'll be taking questions here in just a minute. But just to kind of kick it off, and first of all, I want to thank both of you for those excellent presentations. It's always amazing, and I always admire seeing my colleagues when they're able to boil down what is a career's worth of work into a 20-minute talk. It's pretty incredible. One of the things that I'd like each of you to just take a minute and emphasize is you both gave us some perspective on where your fields are going. If you could each comment on where you think hope lies.
So I guess from my perspective, having a 25-year view of this, I think there's been a shift in medicine in terms of the view of addiction. If you go back in my field and look at textbooks, they would say things like, it's a character flaw, or it's a moral problem. I think we've come very far from that, and there is broad acceptance that there is a biological component that undergirds addiction. And as that's become the case, I think more and more physicians have become interested in it, and more researchers have become interested in it. And with that, I think there is an opportunity for work like the consortium is doing to really implement wonderful prevention, intervention, and to really support folks to really roll out ways to better help. There have been a lot of people dying from addiction for a lot of years. And the attention that's being paid to it now is wonderful in one sense. It's horrifying in another sense. But I think that's where, for me, the hope lies, is that there is a shift from judgment to more empathy. There is a shift from blaming to trying to help. And I think that, for me, is a very substantial change.
You know, Joe, if I can just comment on that, I direct the Center for Health, Work, and Environment. We're focused on how do we have healthier, more productive workers. That's our goal. And there's still a lot of stigma in the workplace related to behavioral health, related to addiction, as well as depression, anxiety, and many other issues. And we're starting to at least see that conversation start in businesses where we're trying to destigmatize, take away the stigma related to these issues. I think we still have a long way to go. And you made the point, Rob, that productivity is impacted by these problems, and that's a huge part of it. And to me, productivity is are people able to feel like they can have a job, hold a job, be successful in their job. I'm really excited by what you're saying. And we are in the workplace, we're starting to see the conversation at least coming up. And I have business leaders asking us, what can we do to take away the stigma and help our employees get where they need to go? So that's starting. Rob, where's the hope?
I think the first thing is that gives me hope is that, treatments, though the effect sizes aren't great, treatment works. There are effective treatments. People, lives can be saved. It's not a death sentence by any means to have an addiction and think there's no hope for me. And there is hope in that. The treatment works, recovery is possible, and happens all the time. It's hard, but it's possible. And and the people really, undergirding all of that is like anyone from what Joe does to providing treatment to policymakers that are interested in this topic, is that people are engaged and collaborating, and now they are talking about it. It's part of, I think, the sea change. And they're talking about it and collaborating. I thought 4 years ago, doing this voluntary thing like this never worked. I thought, sure, I'll take a try at it because it's not going to work. And I'll be out of this in 6 months, and I can go back to doing what I'm doing. And, this won't keep me busy very long. And it has just gone bananas in a good way that people really care, and people really are collaborating and saying, this isn't a competitive thing. We're working all across all the universities in the state, all sectors, people that were normally, competing with one treatment center with another. No, hey, there is so much need, but that's not really the focus. The focus is on doing good work and trying to figure this out. And the legislative committee, when we're down there and the votes are coming out of legislative committee, 10-0 on 4 of those 6 bills, 56 out of 60 votes in a bipartisan was an encouragement to me. 56 out of 60 when we've got 5 Democrats and 5 Republicans on 6 voting on 6 bills. And that was the vote, 56-4, cumulative. Nothing. They couldn't vote 56-4 on today is Thursday. Seriously, I really, and I joked with them about that, and they said, no, you're probably right. We would have 5 or 6 opposing just on principle. And so it's encouraging that people are saying, like, if there's ever a nonpartisan issue that we all have to just sort of get behind. We have a Republican attorney general who's very supportive of naloxone initiatives. A Democratic governor. We have everybody, regardless. That's encouraging to see that, and I think that gives us hope to try to be able to solve things.
I'll add one thing that I think is encouraging that I'm seeing from my perspective. Our center back in 2012, we developed a course for physicians, for practitioners, actually more broadly around the state, on this opioid crisis. And better ways of approaching how practitioners treat their patients who have chronic pain. Because there are better ways of treating chronic pain that do not involve the use of opioids. But I'm of a generation of physicians. I went to school in the 70s, and I was trained in the early 80s. And what I was taught as a physician was break the cycle of pain. Give your patient as much opioid as it takes to break the cycle of pain, And I was taught nothing about other ways of managing chronic pain. So think of generations that have been taught that and then taught other people the same thing and started writing the prescriptions. And the thing that we're seeing is that we've now retrained over 2,700 practitioners in the state of Colorado with our training. We have found out that nearly 80% of the doctors in the state have now taken some additional training on how to address management of the opioid problem and how to better treat chronic pain. We have a team revising our guidelines and our educational approach so that we can reach even more. So what I find hopeful is that more than half of the physicians who take this training come back to us 3 months later when we ask them, they say, I've actually changed the way that I practice. I'm managing people's pain differently. I am prescribing fewer opioids. I am using treatments that are evidence-based and that can help my patients improve their pain. So, and even if we can't improve the pain, we help people get back to function. And that's been more of the thrust, is how to live with the pain and function better. So we're seeing a shift from those of us who started out thinking we just need to write more pills, and you're right, that's what we did, that's what we do, to actually being more evidence-based. Let me ask you both one more question, then I'm going to open this up. So what will it take for you to see the progress that you hope to see in this field? What is it going to take? What is it more research? Is it more funding for research? Is it more aggressive communication? If you had it all, what would it take, Joe, for us to get your field of addiction, of addressing addiction where it needs to be?
Wow. So I think it's multi-pronged. On the one side, I think that one of the big hopes, is research. That's where I've dedicated a big part of my career, is being able to develop a better understanding of what the process underlying addiction is and how we might more effectively intervene and really have high effect size treatments. That would be my hope, is that we can get to that point. I think as treatments improve and move into more mainstream medical settings, there is greater acceptance that this is a problem we should look at, this is something we should treat. We saw that in primary care, as the SSRIs came on board, and family physicians then began to say, oh, well, actually we should ask about depression, and we should treat depression because we can. It's not psychodynamic psychotherapy done, with a psychiatrist or psychologist over a long time. We actually have some medications that we can use that will intervene in the primary care setting. I think there's also a workforce issue of really having more physicians who are invested and interested in addictions work, who can model for younger physicians that this is good work to do. And, there is a specialty in psychiatry in addictions, but now there is an addiction medicine board. And we have an addiction medicine fellowship out of Cedar that has folks from anesthesiology, internal medicine, hospitalists, family medicine docs coming through and training in addictions work. I think those changes are very important and are needed.
Rob, what's your blue sky? What's it going to take?
Blue sky is the first one is, in the short term, I think we need to find out and have the difficult conversations as a society and as a legislature about prioritizing where we put our money and what we do. And we need to take this seriously enough so that anyone who needs treatment knows where to get it and can get it today. And if we're not there, so it should be just like oncology, that if I need treatment, I know I get a cancer diagnosis, I know where I'm going, I know where and how I get treatment, and I get the referral today. And that's how it works with cancer. And if we aren't there yet with substance use disorders, then we're killing off 10. This is just in opioids, and this doesn't count alcohol. It's the largest problem is with alcohol and tobacco. But even on opioids alone, we're killing tens of thousands of people a year by not having those systems in place. And to me, it's just entirely unacceptable, and we need to have that conversation. The other thing is long-term, it's really just going to take an awful lot of education. Like it used to be fine way back when. You have a couple of drinks and you drive home. Hard as that is to believe. Or you're driving around and it's really cool to have a cigarette and you're smoking is cool, and we were there. That took a long time to educate away from public health issues like smoking and drunk driving and things like that. It's going to take a while. But we need to educate everybody about, first thing when they go in is, my pain does not mean I need an opioid. What are my options for treating pain? My pain should be treated, but what are my options? And let people make decisions and inform them of risk. And really, it's going to take a lot of education of physicians and of legislators and lay people to get to where we need to be. And that's the two things I would spend an awful lot of effort and money on, is on both ends.
So let's open this up for questions. Yes. Yeah, please do use the microphone.
Okay. I had a question about the use of stimulants and whether that helps to alter circuits in the same way that like TMS or deep brain stimulation does with someone with executive function issues.
So certainly, for example, stimulants have been studied in the treatment of methamphetamine dependence. There are a couple of studies where people have tried as an agonist approach and a replacement approach to treating stimulant use disorders. The results are pretty mixed at this point. There were some early studies that were suggestive that there may be signal there, and subsequent studies which were not as promising. So I think there are some folks who have tried through medications to alter circuits in a similar way. It's pretty complex, though. Stimulants don't just affect norepinephrine in the frontal lobes. They affect dopamine in other areas. They're reinforcing. They have effects in other parts of the brain. And so I think there have been study after study looking at medications to alter dopamine levels and to also alter circuits in the frontal lobes that haven't been as effective consistently as we would want.
Mean that somebody, you take a kid who has like ADHD who is treated with a stimulant medication, do you think that makes them a higher risk for substance abuse or
no? That's a question that's been asked many times before, and there are longitudinal studies looking at this. And in fact, treating the ADHD does not increase the risk of developing a substance use disorder. So the idea is that, if you treat the ADHD, that you will actually impact that child's course in positive ways. It doesn't increase the risk of developing a substance use disorder down the road.
We have, you're like this now, but you had your hand up before. Do you still have a question?
Yeah. I guess I'm going to go back to, I've heard a lot in the news about, say, the Sackler family and other people known for pushing opioids. And if you're just looking at the side of, let's get people to stop taking them, doctors to prescribe them, what's being done about these pushers out there in the pharmaceutical world? In other countries, France, et cetera, you're not allowed to advertise. We don't do that here. And that's a big factor in the cause of this problem.
Yeah, clearly one of the big factors, it is. The pharmaceutical industry here in the United States operates differently than it does virtually anywhere else in the world. Direct-to-consumer advertising has been legal, then illegal, now legal again. The pendulum has swung back and forth on that one about, is it a good idea to allow pharmaceutical manufacturers to directly advertise to you or to me? And the country has changed its mind on that 3 or 4 times over the last 50 years. But we're currently in a climate where that's allowable, and when that's allowable, the pharmaceutical industry is undeniably very effective at marketing, and both to physicians and to consumers, and creating expectations. And you read about the Sacklers in the lay press, and it's very impressive. And Mr. Sackler developed the techniques to market to physicians and to sell Valium and then Librium and then OxyContin, and has made countless billions of dollars doing that. And so it's definitely an issue, and so it's being looked at in a variety of ways. Do we regulate direct-to-consumer advertising and do regulatory kinds of approaches, and maybe we should be doing more of that. And then on the criminal side, whether it's the attorneys general are now going after various pharmaceutical manufacturers, U.S. attorneys, plaintiffs' attorneys. The industry is now facing tobacco-like scrutiny from the legal community, as probably, as deservedly so, on a lot of this, but to find out, what have people been doing? Was there anything that was illegal? And if so, to aggressively pursue it. I'm a big fan of that. They should be following whatever rules are there, and if there's any variation from it, punish them swiftly. But that's going to take some time, and it will be interesting to see how that plays out. But there's clearly, there's been things that they've already paid large judgments in the past for marketing beyond what has been reasonable, what the evidence showed, what the label showed, illegal tactics as far as influencing people and influencing or paying off doctors, those kinds of stuff, that has existed forever, and it still does. So it's a difficult one to untangle because the money involved is very large, and it's a very complex problem.
And one of the things that there's starting to be some evidence on is the extent to which big pharma deliberately contributed to educating people like me on why we should be pushing opioids, and we're starting to recognize just how behind the scenes, how insidiously that was being done to change the minds of prescribers. One of the things, by the way, that physicians around the state are telling us is that one of their biggest barriers to changing the way they practice, what do you think it is? It's the belief of their patients that they should be getting a prescription for an opioid. So a big thrust of the activities that we have in the consortium are around re-educating the public. So it's one thing to retrain physicians on what they should be doing, and advanced level practitioners, et cetera, on what they should be doing. But if your patients are still coming in because they have this message by way of pharma that what you need to do, doc, is write me this prescription, we still have a ways to go. So we're trying to change public awareness and public understanding. In the meantime, what really infuriates me is flipping on the TV and seeing national commercials from pharma selling constipation meds. Why are they selling constipation meds? Because probably the most common side effect of opioids 40%. Is constipation.
40%.
40%.
It's a real thing.
It's mind-boggling, right?
It's a giant market, giant secondary market that they can advertise. You see it on Super Bowl commercials.
Right.
They're buying Super Bowl time. That's when you know you've arrived at a very high level of marketing.
Yeah.
Look who's paying for this. It's Anheuser-Busch and Coca-Cola and the folks that sell Movantic.
Yeah. Thank you very much. Thank you for that question.
Yeah, great question.
Bill.
Question for Dr. Valak. What are the 4 bills that have overwhelming support in committee and the 2 that don't have such support?
It's a good question. The 4 bills that have strong support are on prevention and education and providing more funding to do this kind of work that we're talking about. How do you go to providers, first responders, and the lay public and do more of that? So I said, yes. And how much money do you need? And I said, $500 bazillion. And so we'll settle for whatever the legislature can come up with. So we'll do as much education as we can. Second is clinical practice improvement. You try to do things with doctors to have them check the PDMP more often, have day supply limits on initial prescriptions for acute pain. Don't give somebody 3 weeks worth or a month worth. Give them no more than a week's worth at a time. That kind of thing, that has strong support. Workforce development has strong support. Creating shortage designations in Colorado, so just like rural providers of primary care or rural psychiatry or whatever, there are shortages. View this as a shortage for treatment, for people that treat substance use disorders, whether it's clinicians or behavioral health of any kind, that we need to create more workforce. And also on the inpatient residential, the possibility of having expansion of inpatient residential coverage under Medicaid and to basically get the state to take the federal benefit that we don't use right now and take the 70% federal matching dollars and invest the money that's needed. The report just came out from the prior legislature that says this would be wildly cost-effective to do it, which we expected and tried to tell them the report's going to say this, because any rational report is going to say treatment is wildly cost-effective, which it is. So that has support. The 2 that have less support is one of them where there was a single vote against on stuff telling doctors what to do, because some legislatures fear the, telling doctors what to do until I'm not going to interfere in medical practice. And the other one that had 3 votes against was changes in payment reform that might require certain, changes to, hey, you can have a prior authorization for medication-assisted treatment or getting someone into treatment, but you can't have 5 days to think about it and issue a prior authorization. You have to do it in 24 hours and consider this an urgent issue. But anytime you tell payers, here's what we're going to make you do, it's different from what you're doing now, and you have to do something more or faster, there is some pushback. And so that one did not have full support, but it was still 7-3. It was still strong support coming out of committee.
Just, I want you to decode one phrase you use, PDMP. Some people may not know about that system. So just tell people a little bit about that.
You know, I live in a world of acronyms. I could probably talk entirely in acronyms with no real words. I said, my kids look at me sometimes. You didn't say anything. But the PDMP is called the Prescription Drug Monitoring Program. It's a database of all controlled substances that are dispensed at pharmacies. So every day, every pharmacy in Colorado has to report the controlled substances they dispensed into this database. So that, starting tomorrow, I can see for you or you, if I'm a doctor or a pharmacist that has legitimate reason with a prescription, can't just go trolling in there to see what Lee's up to. But I can say, okay, Joe wrote a prescription. I have it in front of me. I'm a pharmacist. I can look in the database to see if maybe he didn't just go to Joe, but he went to 7 doctors this week and 10 other pharmacies. And I can identify at least one slice of this problem, which is doctor shopping, pharmacy shopping. And that would obviously indicate someone may have either a use disorder or is diverting or both. Oftentimes it's both. And so you can then have a different kind of intervention then. Okay, we need to talk to this person about the possibility of getting the treatment, or if there's criminal activity, we can identify it.
And yeah, go ahead.
On the physician side, too, we can, when we're sitting with a patient, instead of just taking at face value what they're telling us, we can go in and review what is their history and what have they actually been prescribed in the past. And you can also look under your DEA number. So I can look at all of the scripts that have come out under my name, because sometimes people make up prescriptions. And so being able to look under your number, you can assure that nobody has somehow gotten your number and is doing prescriptions under your name that were not yours.
And one of the things that has changed in this state, and was something that was strongly pushed by this consortium, was having a requirement that every one of us who has a DEA license to be able to write for these medications, to prescribe these medications, we have to at least have registered in this electronic system. We're not required yet to look at it, but we are required to at least be in that system and and therefore know about it. And it gives you an opportunity as a prescriber, before you're writing that prescription, to identify, as you said, is somebody else down the block writing a similar prescription for this patient? Or are they being prescribed the medication that I didn't know about, that didn't tell me about, that the combination could be deadly? So there are benzodiazepines, which in combination with, so these are things that people take for anxiety and for other reasons. That combined with opioids is a particularly deadly combination. And now you can at least spot that by looking into this electronic system. So we're moving in that direction. And nationally, I think there's still only one state maybe that.
Only one state doesn't have one, and about 12 or 13 states now require docs to check that with every prescription. We're getting there, but it's obviously, it takes a while for legislatures to come up with something and do something. They, rarely is the legislature 10 years ahead of a game.
And we even have interstate. So now,
right,
they're
checking across multiple states.
Right. So somebody can't just sort of cross over from Wyoming and us be, blind to what they might have gotten in Cheyenne, and now they're coming to Denver. We have some other questions.
I was curious about what are currently the common referral pathways. I'm guessing it could come from primary care, but not a lot of people have primary care to go to see them. And then 2, in the future, what would you like to see as a best practice for referral pathways for treatment?
It's right now, the best they can say of it is now it's difficult. It's disjointed, it's difficult, treatment is limited. It's really very much a difficult thing to coordinate. The state is making great strides and efforts at the Office of Behavioral Health to take some of the federal money that has come in the last 2 cycles from a couple of larger grants to do, not only treatment expansion, building that infrastructure and capacity, but then building better mechanisms for referral. And that's everything from hiring more people at crisis support services that are trained in identifying and doing handoffs for opioid use disorder specifically, in addition to other substance use disorders. That's one mechanism. Also trying to build better databases of where are the treatment centers and what's going on, what's the availability of this thing. because we don't have a good handle on it. We know where the methadone programs are. They're so tightly regulated that we know where they are. We don't know where every Vivitrol prescriber would be, or buprenorphine prescribers, because they have to have a waiver, but we don't know if they're all prescribing or not. So it's really a difficult landscape to wrap your arms around and know where are the treatment facilities. But that's kind of the things that the state is working on, is to try to figure that out. And then the idea becomes, if there's a central way to come into a front door for whatever use disorder you might have, go there and can be referred to the appropriate network based on your clinical needs and your payer ability and all those things, to refer people to appropriate treatment.
And just, the other part of this puzzle, which is so hard, is that there's a big disconnect between availability of services on the Front Range and the rest of the state. So so in rural communities, it's fine for us to say, boy, I want to make a referral to an addiction specialist, but there isn't one for 150 miles. Right. So we have a big challenge there. Let's take another question.
Andy Kittleson. I'm an assistant professor in the physical therapy program here. So I just wanted to say, on behalf of a lot of the people in the physical therapy community, we really want to be part of the solution. And it strikes me that we're up against a big challenge in how siloed our healthcare system is, in the way of actually having practical ways of collaborating with providers to approach this problem. And I certainly believe that an interdisciplinary approach is probably going to be one of the better ways of getting at chronic pain in society, as well as chronic opioid use. So my question is just, what's being done out there in the way of, practical strategies for encouraging interdisciplinary, collaboration, given how siloed the healthcare system is?
Another really good question. Our provider education work, is identifying, a multi-year strategy to try to, how do we address this? First is, the immediate need. Hey, we have a problem. If you're going to prescribe an opioid or use one, stay within the guardrails so you don't kill somebody. That's kind of where we are. Now it's, how do we ramp up medication-assisted treatment, because you have people with high need. Then how are we doing other things? Next is the upstream question. How do we do alternatives to opioids, including, absolutely, one of the largest effect sizes there is in relieving pain and treating pain is physical therapy. If you want to know what works, it's physical therapy, and that's God's honest truth. For just about any physical ailment like that, physical therapy has been shown to be effective over and over and over again. So we totally agree. And one of those legislative bills, that payment thing, is to make sure that if people are offering coverage, to try to put more teeth into what is parity for substance use disorder treatment, for pain management, and for behavioral health, and including that with pain management, that physical therapy should be covered at reasonable levels. And so we agree with that. I mean, it's a long lift, to get people to turn away from who's dying today, which is of critical importance, but then how are we moving upstream to educate everybody, patients, providers, and payers, that not just going straight for the pen for the opioid isn't the best answer all the time. Rarely is. It should be an option, but it should be last choice, not first line. Physical therapy and other things ought to be first line.
I would just
go ahead.
I would just add, in terms of siloing, I think there is also the funding streams are very siloed as well. Mm-hmm. And so the funding streams for drug-abuse treatment versus mental health versus general medical often have different sort of sources and determinations. For a lot of the programs, historically, where they have had referrals from is criminal justice, right? And many insurance companies would not pay, or would pay very small amounts of money. And as a result, they go where they can actually, treat patients and stay open. And so those funding streams and funding mechanisms are an important part of maintaining those silos rather than breaking them down as well.
Yeah, this is still a tough nut. I train physicians to become specialists in occupational health and how to take care of injured workers. And it's not unusual for the injured worker who has pain to be prescribing physical therapy, but then it gets cut off. You get 6 visits with the physical therapist, 6 and done. When in fact, what they really, if we're going to write a prescription, it ought to be for ongoing activity-based treatment. So we still have some issues with the payers in this state and other states, and not just on the workers' compensation side, but with the healthcare insurers. But we have time for a few more questions. Oh, there's one here, and then we'll come over to you over here.
Dr. Sakai, you showed a graph that had 3 different diagrams on it that showed an astonishing peaking around 18 years of age for susceptibility to addiction. And I'm wondering, do those graphs, are they addressed to a natural propensity for that, a susceptibility, or is in fact there's a social factor that might be coming into play there, alcohol abuse in particular, because there's tremendous youth age encouragement, or at least challenging for drinking, and that would set the stage for that very problem.
That's a great question. So essentially those graphs come from a general population sample called the NESARC. It's about 43,000 individuals. And so it's a general population sample. It's not looking at samples at high risk or at elevated risk in any way. So it's really sort of representative of the general community patterns of onset of these kinds of disorders. Why some individuals go on to develop a substance use disorder versus others don't is multifactorial and complex. My guess is that I probably have risk for addiction, just inherited through my family. But because of my mother's concern for me repeatedly, to my annoyance, throughout high school and early college, I think actually that environmental pressure was helpful to me. Now, if I had been a different kind of kid, maybe that pressure would have pushed me in a different direction, right? And so I think, right, there is an issue of all these factors that impact the prevalence of a substance use disorder in society. One of them is availability. One of them is acceptability, right? And so as opioids became phenomenally more available, you see these graphs of milligrams per 100,000 people being prescribed, and it's just these skyrocketing numbers from the 1990s to the early 2000s, right? Availability increases the risk of development of a substance use disorder. Acceptability within a peer group, within a society, also has an impact. We see as acceptability goes up that there is an increase in use often, followed by an increase in prevalence. And then also perceived risk. So that if there's limited perceived risk of using a substance, often the rates of substance use disorder prevalence go up as well. So we have these epidemiological surveys that track these sorts of things for each substance across time and sort of show these general patterns. So I think it's multifactorial. There are many ways, prevention programs work toward trying to reduce accessibility, improving supervision, improving parental-child relationships, change of neighborhood, things within the school, training and resilience in the kids. So they try and come at it from all those different perspectives in terms of prevention programs, but it just recognizes that it's a multifactorial problem.
And we have this awareness, which this is a disconnect. We have this awareness that, we don't want to put tobacco and alcohol in the hands of kids. And it corresponds to this peak vulnerability period that you showed. Mm-hmm. But we're not doing that with opioids. Mm-hmm. So I'm not going to put you on the spot. I've done this with audiences before. I just want you to think back to the first time that you received an opioid. And most of you have received an opioid. The answer that we usually get is the same answer that I'll give. It's when my wisdom teeth were taken out. So what we've learned is we have to be re-educating the dentists, not to be writing for 30 Vicodin when I don't need any. Or maybe I need one. I probably don't need any after I've had my wisdom teeth out. Now you've just, flooded from the dentist's office into, and you've normalized the idea that it's okay for a kid to have these drugs.
Right? We have some youth who are in treatment for a substance use disorder, go and have their wisdom teeth out, and come back with these huge prescriptions for opioids. And they say, well, what do I do with this?
Got the bottle.
It's a concern.
If it hasn't already been sold to other kids in junior high and high schools. Right. And then diverted. Right. And everyone knows when someone's out getting their wisdom teeth taken out and they're looking to buy the drugs off of them in the schools. So it's part of the diversion problem too. We have time. That was my reminder to keep on time, but we have time for one or two more questions. Yes.
Rob, if I wanted to spend my time uncompensated for the consortium, how would I go about finding out the best use of my areas of expertise?
Thanks. And if you just go to corxconsortium.org, our website, click on the Get Involved button, And there'll be a little form to fill out. And, you can give us your credit card number, how many hours a week you have, whatever resources you want to give us. Joking about the credit card number. But we will say, whatever work groups there are, you can see a description of the work groups and what they're doing and what their objectives are, so you can get a kind of a sense of maybe I'd want to plug in here or there. And then we tell people, we have some people that are in 3 or 4 of those. Some people are in 1 and come once a year. Some people are gluttons like me, and we have, I'll go to every meeting I can. But we would take it's the same thing. We'll take 1 hour or 10 hours of someone's time if you're willing to give it and get you involved.
And this is not only for professionals. We have members of this consortium who want to be out there telling their personal or family story and sharing that with others, because those stories are so important. So there are many ways in which you can engage with the consortium. I have one more hand over here, and that'll be our last question.
Is law enforcement represented on the consortium? And if they are, do you see any change in attitude toward how they are dealing with the opioid crisis?
That's a wonderful question, and they are involved in the consortium to some extent. We're largely health and public health and treatment based. There's a separate task force that was started many years ago, 20 years ago, called the State Meth Task Force. You may have heard of that one. They have rebranded about 5 or 8 years ago to be called the Substance Abuse Trend and Response Task Force. I think we're a big fond of making names that are way too complicated. But that is a law enforcement-based task force largely that we have connected with to make sure that we're bridging public health and treatment and the medical and public health communities with the law enforcement community to collaborate together. And we've worked very closely with them. The Attorney General runs that committee. Cynthia Coffin has been wonderful. And she has worked very hard to educate law enforcement about this issue. For example, to make them aware of naloxone, the overdose reversing drug, because many times, especially in rural Colorado, first person on scene is law enforcement, not a paramedic. And in rural Colorado, that can be 30 or 45 minutes ahead of a paramedic. And so if a law enforcement officer or a sheriff's deputy has naloxone and could administer it as a nasal spray, you or I can give it. I could train you in 30 seconds how to use it. And to be able to do that can save lives, and are doing that. And she paid money to equip 17 counties, the highest overdose death risk counties of the darkest red, with naloxone last year. And we're going down to 30 counties now this year to give them naloxone, train them about it. And now they're asking, gee, how can we get folks into treatment, not arrest our way out of this? So you're seeing the sea change, where last year there were 8 departments that were carrying naloxone and had these questions. This year we're up to 160 departments in Colorado that are carrying naloxone and are asking these questions. And we have a police department in Longmont that started an initiative where if they come upon somebody who wants treatment, they give them a choice. I can take you to the police station and I can book you and we can do this, or I can get you hooked up with a treatment referral and have this person come and walk you and take you through treatment and get you into treatment. It's called an Angel Initiative, and Longmont has it. So it's a very promising strategy to work with law enforcement, and we've seen them really in the last year and a half come around to, really to change the way they're thinking about this thing and wanting to collaborate. Thank you.
So with that, I want a big hand for Dr. Sakai and for Dr. Valek. Just a few final announcements. First of all, thank you all for coming today. You can certainly see the level of passion and commitment from the professors on our campus to helping to not only identify the problem, but really focus on solutions. And I think we should be proud and reassured that this kind of work is going on here. For people who are interested in, we're going to be around for a few minutes afterwards. If you have other questions, we'll try to stay for a few more minutes and talk to people after the session. There are representatives from our advancement office here. If there's anybody here who wants to spend some time getting a tour of the campus, we can certainly arrange that as well. And the other thing I'll tell you is that, so this is the end of this innovation lecture series for this year, but coming up in the future, we want you to look for information about next year's topics. They're going to include things like workplace wellness. I hope that's me. Or some people from my team. Immune modulation, CU innovations, and what we're doing on this campus to support veterans. So those are some of the topics that are queuing up. for next year. With that, thank you so much for taking the time to be with us here today, and enjoy the rest of what looks like another beautiful Colorado day. Thank you. Thank you, Joe. What a pleasure.
Thanks, sir.
Yeah, that's a pleasure.